most of the research I'm going to present today is work that I was doing in Manchester, actually. So we haven't done much mindfulness research in Cambridge, apart from just the research I do on my own mind, you know. So I'm going to be talking about mindfulness, the potential, how potentially helpful mindfulness might be for patients with chronic pain. And I'll be looking at this mostly from a neuroscience perspective. So to just get our minds kind of settled into the topic of mindfulness. So I just want to reflect for a moment on what it's like to be a confused human being, okay? So the Chinese have a term for this, useful term for this, 心猿意马, which means having the emotions of a monkey or the thoughts, and the thoughts of a horse. Okay, so this is nicely represented in this picture. This kind of brings me to one of the paradoxes, if you like, about mindfulness, which is the paradox of control. Like, how do we control our own minds? Okay, especially when you've got this confused monkey and this wild horse. So I'm going to illustrate this with a couple of quotations, or I was going to, but I don't know if I actually have them available. This is where I maybe have struggled to find them. Tell you what, I'll just exit the presentation. Right, maybe you can read them yourself, actually, if you do. So the first quotation was from Xuanzang. Okay, he was a Zen monk from the 6th century. His recommendation was, you must make your mind as pure as still water. Control your emotion monkey's indolence and fidgeting, and restrain your idea horse's haste and galloping. Okay, so that's one point of view on how to control one's mind. The other perspective was said by Shunryu Suzuki Roshi. So he was talking about a sheep or a cow, but he could have been equally talking about a horse or a monkey. I don't know if it's because he was Japanese rather than Chinese. He says, to give your sheep or cow a large, spacious meadow is the way to control him. And so it is with people. First, let them do what they want and watch them without trying to control them. So it sounds like he was talking about other people, but I think he was also talking about his own mind. So this is the kind of paradox of mindfulness. So I'll come back to this later on. So just to give you an idea of what I'm going to be talking about today, so I'm going to be focusing on, initially I'll just give you a bit of background about chronic pain, because I don't know kind of what all your backgrounds are, and I'll briefly say why it's considered a major healthcare problem. I'll then talk about pain from a really kind of basic psychology point of view, and then go into the neuroscience of it. And I want to answer two questions. How does the brain control pain, and how might mindfulness affect the brain's pain control systems? And I was going to spend a bit of time at the end just talking briefly about how the neuroscience research might contribute to changes in the way that healthcare is delivered to people with chronic pain. I don't know if I have very much time for this at the end, so I'm going to keep that quite brief. So I'm going to focus first of all on chronic pain. So chronic pain affects about 1 in 5 people in Europe. Now the biggest cause of chronic pain is back pain, and most back pain does not have a medical explanation. So something like 90% of back pain patients, we can't find a medical solution for their pain. We can prescribe analgesics, but that's about the best we can do. It might be of interest to this audience to note that there's a huge overlap between chronic pain and depression. And there's a lot of debate about which causes which. And it really depends on who you ask. And it's probably one of those chicken and egg kind of situations. I also think it's important to note that, so according to this European survey from a few years ago, 38% of people who have chronic pain say that their pain is not adequately managed. So if you think about that in percentage terms of the population, it's just over 7% of the entire European population say they have chronic pain that's not adequately managed. So when chronic pain patients say their pain is not adequately managed, what do they mean? Well, to answer that question, we have to understand what pain is in the first place, right? So does anybody know what pain is? Yeah? I mean, okay, everybody knows what pain is from one point of view, right? Because we've all experienced it. From a scientific point of view, the concept of pain has changed quite a bit over the centuries. So in the 16th century, Descartes considered pain to be a direct reflection of tissue injury, which sent signals about that injury faithfully up to the brain. So, you know, basically the amount of pain you feel is directly proportional to the amount of injury. Okay? Actually, we now know that's not true. So the extent of joint damage in arthritis, for example, has nothing to do with the amount of pain that people feel. There's just no correlation whatsoever. And so we now understand pain as being partly a result of processing the brain. So the brain has a massive impact on how much pain you feel. And this is to do with cognitive factors like how much attention you pay to it, expectations you have about pain, and also your emotions and moods. So when we talk about pain management, we're talking about three different things. We're talking about the sensation of pain, the emotional and the cognitive aspect. And pain sensation, if you like, is normally considered a medical or a kind of biological problem, whereas the emotional and the cognitive aspects would normally be considered a psychological and social problem. Now, an important concept in pain psychology, and this might be the case in other fields as well, is the concept of self-efficacy. So self-efficacy in terms of chronic pain management basically means the perception that somebody has about their ability to manage their symptoms and also manage possible causes and also the consequences of those symptoms in their life. This is an important concept because people that have high levels of self-efficacy tend to recover very quickly from an acute pain episode, like acute back pain. People that have low self-efficacy are much more likely to transition to a chronic pain condition. So how can we improve self-efficacy? So the kind of current gold standard, if you like, is multidisciplinary pain management programs. These have the best outcomes. So these are tertiary care programs that look at both, look at the sensory aspect of pain, the emotional aspect, and the cognitive aspect. So, you know, the biological, the psychological, and the social. And that's why they have the best outcomes. But they're not very widely available. There are also third sector support groups and pain self-management programs, but their existence is a bit patchy, and the quality of them is also a bit uncertain and variable. So most people that have primary care are really treated in, most people that have chronic pain are really treated in primary care. So they're reliant on the knowledge and the training of their GPs about chronic pain, which unfortunately is also very patchy. And as a consequence of that, a lot of patients are really left to manage the psychological aspect of pain themselves and through their own self-learning. So how can we improve on this? So maybe this is somewhere that mindfulness can help, right? So this brings me on to my second part of my talk. So let's look at let's look at the psychology of pain. So I'm going to be looking at this from a really kind of basic, simple level because I don't know what everyone's background is, right? So this is my pain psychology for dummies. And I'm going to try and relate this to kind of what might be, hopefully, a personal experience that you might have had. Yeah? So I'm actually talking about a personal experience of mine, but hopefully this will relate to you. So let's say you're taking part in some activity that you enjoy or you think it's good for you, such as going for a run, and you get some knee pain. Maybe you cause yourself a slight injury. And if that happens a few times, you might actually become somewhat conditioned to believe that running causes pain, right? So this is just basic associative learning, right? Even the most simple animals can do this. Like a fly can learn these kind of associations. So one of the effects of this is that when we then start to think about going for a run, we have an expectation that we'll be in pain, right? It's very simple. What results from that? Well, we might feel afraid. So this is our emotional monkey, right? But as humans, we don't just feel afraid. We think about our fear, right? And we think about all the possible negative consequences of that thing we're afraid of. So we call that catastrophizing. And this is like our uncontrollable horse, right? Our thoughts running around all over the place. What's the consequence of this? Well, one consequence is actually enhanced pain. So there's now a large body of literature, largely from experimental studies in the laboratory, that show that if you have expectations of pain being at a high level, then you actually experience it as being higher. So like your expectations partly create your reality. So here's just an example of some data from a PhD student of mine in Manchester, just showing the difference between having a positive expectation and a negative expectation. So in this case, the difference is somewhere around 20%, and somewhere between about 10 to 30% modulation by expectation is quite typical for these kind of experiments. And that's really on a par with a mild analgesic, so it does have quite a significant impact. What else do we do? Well, so I should mention that one of the things that having greater pain will do is it will actually kind of feed back to reinforce that negative expectancy, right? So we might also then start to avoid activities that cause pain. We might decide that going running is not a good idea. And this can be problematic as well, because this can actually, essentially it prevents the opportunity for that fear to be extinguished, right? Because for fear to be extinguished, you have to have the conditioned stimulus, which is the running, in the absence of the unconditioned stimulus, which is pain. So unless you experience that, then you'll always be afraid. So this is problematic. The last phenomenon which I want to draw your attention to is something called generalization. So this is just starting to be looked at in chronic pain, just in the last few years, really. And this is a process where you're afraid of running, but then that fear generalizes to other things that are a bit like running, so just going for a walk. So you can see how, if this cycle continues, people will just become more and more disabled. And this is a version of what's called the fear avoidance model. So this is probably the most influential cognitive behavioral model of chronic pain and disability that's been in existence for about 20 years now. So where could mindfulness come in to help with this, right? So mindfulness is, certainly the way that it's talked about in the scientific literature, it's largely seen as a form of cognitive training. So it involves these different elements, focusing on the present moment, acceptance and non-judging. So one would expect, therefore, that mindfulness would have its biggest impact on the more cognitive aspect of this cycle. So you'd expect it to inhibit catastrophizing, because catastrophizing and mindfulness are mutually exclusive, right? If you're catastrophizing, by definition, you're not present because you're thinking about some terrible thing that might happen in the future. You're not accepting of your current situation. You're judging the situation to be threatening, right? So, so these two are mutually exclusive. But the cognitive aspect of mindfulness could potentially have a direct impact on fear itself. And I'll talk a bit about possible mechanisms by which cognition can impact on fear. A third way that mindfulness might help is from the behavioral side. So I think maybe the behavioral aspects of mindfulness are not really talked about so much. I don't remember reading much recently about that. But surely one of the consequences of being more accepting is that you're able to turn towards experiences that you might be afraid of. So this is going to have an effect on avoidance, right? It's going to basically reverse that. There's another concept which is committed and values-based action. This is more probably associated with acceptance and commitment therapy, perhaps, or certainly in the scientific literature. But certainly you can see how it would, if you think about the Buddhist roots of mindfulness, and the importance of values-based action within Buddhism is quite apparent. So I think the behavioral aspect of mindfulness is something that we also need to consider, and this would have an effect potentially of helping to extinguish fear. Okay, so that's the end of kind of Pain Psychology 101, and so I'm going to move on to talking about a bit of data. So this was a research study I did a really long time ago actually. Probably started collecting data on this about 11 years ago. And the idea was to find out if people who practice meditation feel pain differently from people that don't. Like, very simple idea. And so we recruited people with a wide range of experience in meditation. They all said that mindfulness of breathing was a major component of their meditation practice, it wasn't necessarily the major component for everybody. So, for example, there were Zen practitioners who often use mindfulness of breathing to help them in their practice, but it might not be their main practice. And you can see the range of experience here goes from 10 months to 34 years, so massive range. And we compared them to a control group who had no meditation experience. And the way we compared them, first of all, was by inducing experimental pain in the laboratory, and we wanted to see if their pain threshold was different. So we gave them these laser zaps, right? So it's like a very brief heat pain stimulus, and it just feels like hot pinprick sensation. And we gradually increased the intensity of the laser until they said it's just starting to get painful. And what we found was there was absolutely no difference between the meditators and the control group. So we thought, okay, that's interesting. So people that meditate don't feel less pain. Do they differ in some other respect? So we had a look at, what we decided to do is just set the level of pain to be at the same level for everybody. So they were rating it as a 7 out of 10, which is a kind of moderately painful level. And then we asked them to tell us how unpleasant they found it. So this is now getting more at the emotional aspect of pain, the kind of negative appraisal of pain, if you like. And this is what we found. So initially, when we compared the meditation group to the control group, there was absolutely no difference, yet again. But you can see there's quite a range in the meditation group. And when we just picked out those people that had more than 6 years of experience practicing meditation, we saw that there was a difference compared to the control group. And representing that differently here, you can see there's a negative correlation between the extent of their meditation experience and how unpleasantly they were finding pain. So this is promising. This is suggesting at least long-term meditation practice has some effect on how people regard pain. They don't find it quite so unpleasant. Does this then, is this going to be helpful for chronic pain patients? Because if you're giving them like an 8-week MBSR program, is it really going to have any effect? Okay, so this is where we followed this up in a group of chronic pain patients, and this study was funded by the Mind and Life Institute, a Varela Award. So we recruited, this was a fairly small study, so we just recruited, we had 28 patients in the end who completed the study. So they had some baseline assessments and were randomized into intervention and control groups. So the intervention group underwent the Breathworks pain management program, which is a mindfulness-based pain management program, very similar to MBSR, but really focused more on pain management. And the control group just had usual treatment, but were offered the Breathworks program at the end. So here were some of the assessments and the results that we got. So one of the things that we were really interested in was whether the mindfulness program helped people to self-manage their pain, and this is where we got possibly the largest effect. So there's possibly almost a doubling in scores on this questionnaire measure of engagement in a self-management approach to chronic pain. We also measured perceived control over pain, which is a concept that's very similar to self-efficacy, and it's very highly correlated with self-efficacy. And again, that improved. So this is maybe why people are better able to self-manage their pain. They feel like they have a bit more control. So here's this idea of control coming up. So if people feel like they have more control over their pain, does that mean that they have less pain, necessarily? Turns out, when we measure their pain in terms of the sensory aspect, so this is just a list of different sensory qualities of pain and how kind of severe they are, there's absolutely no difference. When you look at the emotional aspect or the affective aspect, there is a slight reduction. So this is even after only 8 weeks. It's starting to look like they're appraising their pain slightly differently. The bigger effects, though, really were in pain catastrophizing. So we saw quite a substantial reduction in catastrophizing and an improvement in overall mental health. So this is looking kind of promising, right? But we still don't know, on the basis of this data, exactly where mindfulness might be having an effect. We don't know if it's directly inhibiting catastrophizing. We don't know if it's actually inhibiting fear itself, and that's then just having a knock-on effect on reducing catastrophizing. It could just be having no cognitive effect whatsoever, and maybe people's behavior is changing, and there's some fear extinction going on, right? So there's still no real insight into the mechanism. So let's start looking at this from the point of view of the brain. So if you look at the areas of the brain involved with associative learning of fear, it's largely the amygdala, orbitofrontal cortex. So these are the areas that kind of start to associate pain and conditioned stimuli. And this is what gives rise to these conditioned responses via the brainstem and the hypothalamus. So this is our fearful monkey, if you like. So this is common to really a lot of animals. So what happens in human beings once you've induced an expectation of pain? What happens in the brain as they're anticipating pain? Well, what we see is activation of a network of brain regions that's now commonly referred to as the salience network. So this is the insular cortex, predominantly the anterior insula, and the mid-cingulate cortex. And this is, the more these areas are active, the more cognitive resources are being put into, in this case, anticipation of pain. So I'll show you a little bit of data on this and how we go about measuring this. So this is a very old photo of me donning also a very old EEG cap. And this device just in front of me is the laser, and it's pointed at my arm. So although I look really relaxed, and maybe it looks like I'm falling asleep actually, I'm actually really scared. Okay, because I've just been told I'm about to experience something painful. And this is what's happening in my brain before I'm told I'm about to experience something painful. I then get an anticipation cue. It tells me to expect pain in about 3 seconds' time. There's an evoked potential that just responds to that cue. And then there's the shift in the baseline of the EEG towards the negative polarity. And if you look at whereabouts on the scalp that negative polarity is, it's mostly frontocentral. And it's the insular cortex and the mid-cingulate that are essentially generating this negative polarity. There's then a laser stimulus and a laser evoked potential. And the largest laser evoked potential peak is the P2, which is this kind of a positive polarity that's also largely in the center of the head. So just to prove to you these regions are important, so here's a meta-analysis of functional imaging studies measuring anticipation of pain, and you can see the mid-cingulate cortex and the insula are amongst the most activated regions. They're the most kind of robustly, they're the most kind of robust findings in terms of pain anticipation. Now, when we look at that EEG data again, and we look at the anticipation and then do some source analysis, so we actually work out whereabouts in the brain that signal is coming from. So I was picking up the anterior insula, just much as those fMRI studies were. And I found that the more this area was active, the more people's pain perception was influenced by their expectation. Okay, so we're giving people different anticipation cues, and that was inducing changes in their expectation. And we found that the anterior insula seemed to be predicting how influenced they were by their expectation. And this has also been found in an fMRI study more recently. Here they did a whole brain analysis where they applied a formal mediation model to identify regions of the brain that mediated the relationship between anticipation cues and pain perception. And they found this network. Okay, this is a study that went on in the United States, so this is not my work. They found the anterior insula again, what I refer to as the mid-cingulate cortex and the thalamus. Okay, so this is the salience network that we're seeing here that's becoming more active during anticipation of pain, and that seems to mediate the effect of your expectations on pain perception. Now, the mid-cingulate cortex is widely known to have another function, which is to do with cognitive conflict and also emotional conflict. So what does this mean? This is like when you're trying to focus on a task and then something comes along to distract you, and your attention kind of automatically goes towards that thing that's distracting you. But that's not then consistent with your goal of paying attention to the task, okay? So then the mid-cingulate cortex gets really excited and it tries to exert control over your attention again. Okay, so just to illustrate, here's a study that I did where people were doing this exact thing. They were trying to focus on a task, and we could measure the errors in the task. And we looked at what effect anticipating pain had. And the people that performed worse as a result of anticipating pain were activating this mid-cingulate cortex more. So it was trying to get them to refocus their attention back on the task. And what the mid-cingulate cortex does then is it recruits the frontoparietal executive control network. So this is the dorsolateral prefrontal cortex and the inferior parietal cortex. So you might think that these regions have some importance for chronic pain, right? Because if somebody has chronic pain and they want to go about their daily activities, but they're always attending to their pain, they're not going to be able to get much done. So we had a look at this in chronic pain patients. And what we found was that the dorsolateral prefrontal cortex, so these regions involved with executive control, were on the whole less active in chronic pain patients than in healthy volunteers while they were anticipating pain. And we found that the less that these regions were active, the more they were catastrophizing and the more anxious they were. And this was more recently replicated in an fMRI study by another group. So this was specifically a study in fibromyalgia patients where they found less dorsolateral prefrontal cortex activity predicted higher scores in pain catastrophizing. And they also found actually it predicted how sensitive people were to cuff pressure, which is one of the things that fibromyalgia patients are particularly sensitive to. So the reason I'm telling you all this is so that you have an idea about the different kind of pain control networks, so we can start to understand where mindfulness might be starting to have an impact. One thing I should also mention is the medial prefrontal cortex is a really important region. So this area is probably quite well known now, for, especially in the mindfulness world, for being involved with self-referential thinking. And it's one of the areas that's actually deactivated by the dorsolateral prefrontal cortex. So there's almost like a tonic, it seems to be a tonic inhibition on the medial prefrontal cortex. And yet, when there is a need for emotional regulation, like when there's some kind of emotional conflict that needs resolving, this area actually becomes more active, and it acts by inhibiting these kind of more primitive limbic system areas. And it's thought it might contribute towards kind of cognitive fear extinction. Okay, and just to kind of illustrate this, this is an image from a review just showing that through cognitive regulation in the dorsolateral prefrontal cortex, this can recruit the ventromedial prefrontal cortex and have an inhibitory effect on the outputs from the amygdala. And also just to illustrate too, these same brain areas appear to be very important in depression. They seem to be dysregulated in depression. Okay, so this brings us back to our kind of hypotheses about how mindfulness works. Okay, so is mindfulness is it kind of inhibiting catastrophizing through greater cognitive control? Is it actually having an effect on fear extinction by activating the medial prefrontal cortex? Or is it just something completely behavioral and has nothing to do with cognition at all? Okay, so let's start looking at some imaging data from mindfulness and meditation studies. So this is not my work. This was an fMRI study done by a group in the US. And this was really a neatly designed study. They had people who were quite experienced in meditation, and whenever those people were in the scanner meditating, and whenever they noticed their mind wandering off, they pressed a button. Okay, so that button press indicated when they first became aware that their mind was wandering off. And what happened at that point in time, was activation of this salience network. Okay, anterior insular cortex, mid-cingulate cortex. Now, in this group of meditators, their task was to focus on the breathing. So they actually then had to redirect their attention back to their breathing. So what we see then is activation of the frontoparietal executive control system, and then a refocusing of attention, which also seems to involve that same system. But, and I'm not sure I've seen this data yet, but you might imagine that different styles of meditation would have slightly different effects. So maybe a more open monitoring meditation where you're not necessarily having a single focus of attention. You might not expect the frontoparietal network to be involved, but you might still expect the salience network to be really active. Okay. So this brings me back to the case control study I mentioned before, where we just compared experienced meditators and controls. So we actually recorded EEG data during the study, and we looked at anticipation of pain. And so the question is there any difference in these brain networks, the salience network and the executive control network, in the people that meditate while they're anticipating pain? So what we found was that meditators are not anticipating pain so much, it seems. So there's just generally seems to be less brain activity. At least so insofar as we're recording it on the vertex of the scalp. And it turns out that that is explained by less activity in the mid-cingulate cortex. So it looks like anticipating pain is less salient to meditators. This is just to show that this occurred during the late phase of anticipation, just before they received a painful stimulus. Now, the less they activated mid-cingulate cortex, the less unpleasant they found pain to be. So this was a correlation in the meditation group. There's no relationship in the control group. And the less they were activating the more experience they had in meditation, the less they were activating the mid-cingulate cortex. So this kind of maybe explains why we have this relationship between meditation experience and unpleasantness. This has something to do with they seem to be able to somehow down-regulate the mid-cingulate cortex. So they have an expectation of pain, but that expectation is not kind of hijacking the salience network, and it's not influencing their pain perception so much. So here's an fMRI study that was published more recently from another group in the United States. This is Richie Davidson's group. They basically looked at much the same thing. They were using fMRI to measure anticipation of pain, and they were comparing expert and novice meditators here rather than kind of expert and just controls without any meditation experience. And their main findings were actually more focused on the anterior insular cortex. So this is just the other node in the salience network. I was picking up more mid-cingulate. They seem to be picking up a bit more of anterior insular. And they find exactly the same pattern. So if you look at this graph here, during anticipation of pain, in red here is the meditation group, and in blue is red is the expert meditators, and blue is the novice meditators. So the experts are not activating that area so much during anticipation. And yet you see, during the actual experience of pain itself, the insular becomes more active. So pain itself appears to be more salient, but anticipation of pain is less salient. The other interesting finding from this study was that in the expert meditators, they were not activating the amygdala so much during anticipation. So this is quite exciting, because it suggests the expert meditators might actually have some control, a bit more control over their emotions, or their fear in particular. And if that's the case, you might expect the medial prefrontal cortex to be involved, right? And that's exactly what I found in the EEG study. So the meditation group actually had higher activity in the medial prefrontal cortex during anticipation of pain. And interestingly, while in the meditation group, the more they were activating this region, the less unpleasant the pain. In the control group, we had the exact opposite correlation. So it looks like if you don't meditate, it's an advantage not to activate your medial prefrontal cortex, because you're going to find pain less unpleasant that way. But if you're a meditator, you want to be activating that region more, right? So that's pretty weird. So how do we explain that? Yeah? So let's reflect a bit on what this region of the brain is doing. So here I've highlighted the particular region that was more active in the meditation group. And here's a list of different phenomena that have been associated with activity in this region. So I put self-reflection there on top because it's possibly one of the more familiar topics for people that are interested in mindfulness research. There's also some literature on the resolution of emotional conflict. So I mentioned that the mid-cingulate cortex is really picking up when there is conflict that needs resolving. But the resolution of that conflict, it seems to be associated with activity in the medial prefrontal cortex. And as you can see from this figure, in terms of fear, the more kind of dorsal areas of the cingulate cortex tend to be positively correlated with amygdala activity and are involved with appraisal or expression of fear. And the more ventral areas, which is a bit closer to where this area is, are more involved with regulation. Although this area seems to be maybe almost overlapping these two functions. Now this finding has since been replicated in an fMRI study. It's always nice when you get some EEG results and they're replicated in an fMRI study. So here, this was, I'm not sure exactly where this study was done actually, but it was by Tim Gard, who now I think works in the US. And they found that people with, the Vipassana meditators who were quite experienced were also activating this area more during anticipation of pain. So the exact same area. So it's kind of like on the genu of the cingulate cortex, right, that perigenual region. But they don't just activate that area more during anticipation of pain. When they're meditating, like, so when comparing meditation in somebody who's experienced at meditation to meditation in somebody that's not so experienced, the experienced meditators are activating this region more. So you don't even need to be kind of anticipating something threatening. There was also some literature that at first sight seemed to contradict this evidence. So in this study, some experienced Zen meditators were in the fMRI scanner experiencing pain. And what was found in this study was actually they were decreasing activity in the medial prefrontal cortex. So when I first saw this, I thought, oh, that's really different from what I've seen so far. But is it really? Well, in fMRI studies, when they're looking at pain activations, they're looking at pain versus a baseline. And the baseline in fMRI studies is actually normally the anticipation phase. So unless you've actually explicitly tried to measure anticipation and model for it, when you're looking at pain responses, you're looking at pain versus anticipation, not pain versus like a pre-anticipation baseline. And actually, if you look at by EEG data, you see the same thing. So moving from anticipation to pain, there's actually a decrease in activity in the medial prefrontal cortex. In controls, possibly even an increase. So I don't know whether this is all kind of confusing, right? Because there's all these different time points. There's kind of baseline when people are meditating, there's anticipation, and there's pain. The brain seems to be doing different things at all these different phases. So let me just summarize this for you. So the salience networks are upregulated during meditation. They are downregulated while anticipating pain and appear to be actually more sensitive to the experience of pain itself. So what does this mean? This rather suggests to me that meditation is increasing present moment salience. Okay, so when something happens in the present moment, like pain, the salience network is more active, but when you're just anticipating something happening in the future, it's less active. Could this be as a result of greater emotional regulation? Because as I said before, if the amygdala is like really active, and that activity kind of hijacks the salience network, that appears to be what is explaining why people are more influenced by their expectations, right? So just to summarize what I showed you about the medial prefrontal cortex, which actually has an inhibitory effect on the amygdala. So that is upregulated during meditation. It's also upregulated even further during anticipation of pain. and yet during pain itself, it doesn't seem to be activated as much, which is kind of curious if you think about it. But maybe it's just because there's already such a high level of baseline activity here that people just, if you're a meditator, you've already got this region really active, so you don't need to activate it very much more when pain comes along. That's one possible interpretation. So this is really exciting, potentially, right? Meditation seems to actually improve people's emotional regulation. This could have really important effects for managing chronic pain. But what about short-term training? Because we want really to be able to see beneficial effects after a much shorter time span than 30 years, right? If we're talking about the really kind of experienced meditators here. So, so there have been plenty enough studies on short-term meditation, and I showed you some data from the chronic pain patient study that I did. And I'll come back to that in a minute. So short-term mindfulness training seems to improve performance on attention and executive function tasks. When people with relatively short-term training are meditating, they're also upregulating the same salience network. So this is looking quite promising. They're doing the same thing, it looks like, as the longer-term meditators. But when you look at the pattern of deactivations, they're actually deactivating the medial prefrontal cortex during meditation. So this is the opposite of what we're seeing in the longer-term meditators, in the experienced meditators. So does that mean that there is a difference in the way they're anticipating pain as well? So here is the EEG data from this small clinical trial that I did in chronic pain patients. So the dashed lines here in the middle are where we assessed anticipation of pain at baseline. And there's no difference really between the mindfulness group and the control group. After training, which is these solid lines, anticipation seems to have reduced in the mindfulness group, and in the control group, if anything, it's increased. It's almost as if the control participants, having attended a session already 8 weeks earlier, had become conditioned to anticipate pain from this laser stimulus. So their anticipation response is actually augmented. But when we look at the regions of the brain that are generating these responses, are they the same pattern that we see in the more advanced meditators? So one really encouraging result from the study was that early on during anticipation, we saw an increase in activity in the dorsolateral prefrontal cortices bilaterally during anticipation of pain. So if you remember the results I showed you from the chronic pain patients, so chronic pain patients generally have less activity in these regions, and the lower that activity, the more they catastrophize. So here we're maybe seeing some kind of normalization of function in the prefrontal cortex. And in fact, the more activity there was increased by the intervention, the greater perceived control over pain that was reported. What about the late phase of anticipation, so just before pain? So this is where, in the advanced meditators, we saw less activity in the mid-cingulate, but greater activity in the medial prefrontal cortex. Here we're seeing the opposite. So we're actually finding that after 8 weeks of training, chronic pain patients are down-regulating their medial prefrontal cortex during anticipation of pain. So this is actually consistent with what I just showed you. Short-term meditators are doing while meditating as well. They're also down-regulating the medial prefrontal cortex. So we seem to be seeing a dissociation here between short-term and long-term meditation. They also were activating the insular cortex less during the actual experience of the laser-induced pain, which is again is the opposite of what we found in the experienced meditators. There we found greater anterior insular activity, as if pain was more salient for them. And just to show you that this is not necessarily some artifact of studying chronic pain patients or something weird about doing EEG experiments rather than fMRI experiments, here are the results from an fMRI experiment in healthy people. And this is showing changes in pain processing, okay, not anticipation, but just pain processing. After only 4 days of mindfulness meditation training, which incidentally was found to reduce pain unpleasantness after only 4 days. So was found here was, again, a reduction in activity in the insular cortices, and what looks like actually greater activity in the medial prefrontal cortex. Not quite clear if it's the same region as what we were looking at before, but somewhere in the medial prefrontal cortex, they're actually activating this area more during the experience of pain. So again, I'm aware that this may be confusing, so I've summarized it for you. So this is the pattern that we got on top here for the experienced meditators. For the less experienced meditators, they are actually activating the salience network during meditation. So they're doing something which is similar to an advanced meditation practice. But when anticipating pain, they're not inhibiting that salience network. And in fact, when they experience pain, they're even down-regulating that salience network. So it's the precise opposite of what we see in the people with more extensive meditation training. So what could be causing this? Well, so pain expectancy seems to be still quite salient for people. So you practice meditation for 8 weeks, but you're still, the expectation of pain is still kind of hijacking your perception. So there's two ways of looking at it. One is that present moment salience is less stable. People's thoughts are still kind of taking control of their consciousness and influencing their perception quite a bit. And another way of looking at this maybe is to do with emotional regulation. So if we look at that data, so here's the data here's the summary of what happened in the meditators with extensive training. After any brief training, we see the exact opposite results. So they seem to be down-regulating medial prefrontal cortex activity. They're down-regulating further during anticipation of pain. And then during the experience of pain, there's actually, well, from that one study, there appeared to be greater activity during pain. One thing that we do see, though, in the people after brief training is greater activity in the dorsolateral prefrontal cortex. So it's not clear if that was, if you only see that in people who already have some deficit there, or if that's like a general effect of brief meditation training. But that might explain to a certain extent why we at least saw some improvement in the chronic pain study on the affective judgment of clinical pain. It was quite a subtle effect, but it was just looking like it was going in that direction. So it could be that people with brief meditation training, the way that they regulate their emotions is more through this kind of executive control network. And this might be resulting in more of a kind of blanket suppression of what's called the default mode network, this kind of self-referential thinking, which includes the medial prefrontal cortex. But this might actually have a knock-on effect that they're not regulating their emotions quite so efficiently, because some level of self-reflection is actually really useful when it comes to regulating emotion. The more aware you are of your emotional state, the easier it is to regulate. So my conclusion from this, and so this is kind of like, what advice do we give our poor monk here who's being carried away by his uncontrollable horse and restless monkey? Well, so if he engages in an 8-week program of mindfulness-based stress reduction, you might expect that he'll be able to tame that wild horse a bit. So this is like the pain catastrophizing. And this may happen by an improvement in executive control. Extensive meditation training, so if he continues this training for I don't know how many years, we might start to see an improvement in emotional regulation. So the emotion monkey will be pacified. And this, in my mind, starts to resolve this paradox of control a bit. So when people first start to meditate, I think the practice is quite a controlled practice. People are becoming aware that their mind is wandering off, and if they're anticipating pain, then one of the things they might be thinking about is something painful, or something in the future that might be painful. And the way they deal with that is by essentially trying to either suppress that emotional response, or just narrow the focus of the attention. Right? Because if you focus on the breathing so that the attention is very narrow, that can have the effect of calming the mind down. But it's it's a very kind of exclusive focus of attention. You know, you become very narrowly focused on one thing, like the movements of the breath, right? Calming, but it's not kind of including the range of emotional experience that you might otherwise have. Whereas I think when people become more advanced, people's emotional experience starts to become more included within that kind of very stable kind of present moment salience. And in that situation, there isn't such a need for control, because everything that arises is another thing that's just okay to be there. It's just another kind of feature of consciousness. Okay, so this kind of paradox is maybe resolved by looking at kind of different levels of familiarity with meditation experience. So I don't know how we're doing for time. Are we kind of? I had a feeling that we might be running over. 5 minutes left? Yeah. Okay. So that's good, actually. That's good. So I've only got a couple more slides. So I wanted to look at this almost like changing tack completely, right? So I wanted to look at this from the perspective of healthcare technologies, and because I'm going to keep this brief, I'm just going to focus on one very small aspect. So I don't know if you've come across the concept of neurofeedback. So it's been around for a long time, actually. It's been around more in the EEG world. So neurofeedback therapies are now considered quite useful for things like the attention deficit disorders. In the last 10 years or so, there's been growing interest in using fMRI for neurofeedback. The advantage of this being that you can focus in on particular brain regions, or you can look at very precise networks of brain regions. So here was a study from about 10 years ago, and what they found was, so I should explain how this works. So a signal from a particular region can be fed back to that person as, say, a visual representation, maybe just some image on a screen. So people can actually see the activity in that particular brain region, and either through a process of trial and error, or by adopting a cognitive strategy, they can learn to voluntarily upregulate or downregulate that activity in that brain region. So there's a delay in fMRI. There's a delay of a couple of seconds, so you get maybe a few seconds delay in what your brain is actually doing, but it still appears to be effective even with that delay. With EEG, you just don't get any delay at all. So in this study, they had healthy people experiencing acute pain, and also chronic pain patients learning to up and down regulate the mid-cingulate cortex. So this is obviously a really important region involved with pain salience. And they were finding that here in the experimental group, over a period of, I think for these kind of studies, they normally have about 4 sessions. So to start with, people are really not very good at regulating their brain activity. And then by the 4th session, they're getting quite good at it. So by the 4th session, we're seeing really quite substantial changes in pain intensity and unpleasantness ratings. So this is interesting, because this suggests, when we're thinking about the kind of neural signature of meditation, if you like, this suggests that we might be able to actually train people to meditate using this kind of technology. And in fact, there's already work going on in the United States to look at precisely this. So I don't know if you're familiar with Judson Brewer. He's doing some work trying to train people to meditate using neurofeedback. And his approach is to focus on the posterior cingulate cortex. So this is one of the areas of the default mode network that becomes less active when people start to exert cognitive control and start trying to concentrate on something. And his view is that the posterior cingulate cortex represents the feeling that you have of being consumed by your experience rather than being kind of decentered from it. So he's had people in the scanner, and so far he's compared experienced meditators to non-meditators. And so here in blue is down-regulation of the posterior cingulate cortex, and red is up-regulation. So you can see here that people that meditate are already quite good at down-regulating their posterior cingulate cortex. So this is now going forward into clinical trials, and they're going to now look at seeing whether this kind of neurofeedback can actually accelerate people's learning of mindfulness. So just a word of kind of caution, I suppose, about this. So if reflecting on the data that I was just showing you, the medial prefrontal cortex is part of that same default mode network, and it's highly correlated with activity in the posterior cingulate cortex. Now, it could be that as a strategy for learning meditation in the first place, it is useful to learn how to downregulate your default mode, but in the long term, we can see that in order to improve emotional regulation, you need to learn to upregulate your medial prefrontal cortex. Okay, so this is the data I showed you. So this rather suggests that we should be looking at neurofeedback on multiple brain regions and dissociating different areas of the default mode network. So upregulating medial prefrontal cortex, downregulating posterior cingulate might be one kind of strategy for teaching people how to meditate. And obviously fMRI being like this big expensive technology is, you know, it's not like people are going to be doing this every day at home. So one outcome of this work is going to be to translate these findings into EEG. So if you can study this in an fMRI scanner and then also look at what's the neural signature of these brain regions in EEG, then potentially you can get people doing this at home. Because there's now, I don't know if you've come across these kind of low-cost EEG systems, they're now used for things like computer gaming. So for a few £100, you can actually monitor your prefrontal cortex. And I don't know how reliable it is, but this is the way that technology is going. So, you know, in 10 or 20 years from now, we might all have these EEG systems, and we might plug ourselves in every evening to help us learn how to kind of upregulate our medial prefrontal cortex. So this is a vision for the future. Okay, so just some general conclusions. The way I see this data is meditation seems to evolve from a practice of cognitive control to a practice of emotional regulation, where control is less of a feature. And this involves different, in many ways seemingly opposite, brain network dynamics. In the future, technology may be able to facilitate emotional regulation through real-time monitoring and feedback of meditation-related neural activity.